we must know the stable asthma, acute severe asthma, and life-threatening asthma. This part is very important, and in the discussion of the bronchial asthma, we will tell the definition and the sign, symptom, and diagnosis. After bronchial asthma, we'll learn about COPD, chronic obstructive pulmonary disease. Admit করেন অনেকগুলো আছে। COPD. In the case of COPD, chronic obstructive pulmonary disease, do you hear me or COPD, chronic obstructive?
স্যার শুনতে পাচ্ছি স্যার, নেটওয়ার্কে অনেক সমস্যা স্যার।
Network.
Yes, sir.
Class ki accept the technical problem and let us continue with the class. Otherwise, we will miss. Just these are the topics for the lecture. COPD, chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. And this chronic obstructive pulmonary disease comprises of two diseases. You please write. That is a great problem that we don't understand what is. One is chronic bronchitis and chronic emphysema. So it is a এই ওটা বন্ধ রাখেন লাগবে না বাবা, প্লিজ আপনি এটা বন্ধ রাখেন। Important class, online class, it's not inline class, so there are many person waiting. So chronic obstructive pulmonary disease comprises chronic bronchitis and chronic emphysema. The third disease for the respiratory system is pneumonia. That is the inflammation of the parenchymal tissue of the lungs. And when we will teach the lecture, we will go through the system, examination, diagnosis, and of course the treatment, complications, all diseases. Number, pulmonary tuberculosis. Will be very interested history, diagnostic criteria, treatment modalities. We will discuss on the third. We will try the related to tuberculosis is effusion. Effusion, that collection of the fluid in the pleural cavity. Then the pneumothorax. These are the most important topics we must go to learn. that is the pneumothorax. Another is the hypopneumothorax. After that, we'll try to learn the bronchial carcinoma, bronchogenic carcinoma. We'll try to learn the bronchogenic carcinoma. Sometime after these diseases, some industrialized occupational lung disease, lung fibrotic disease, and the bronchiectasis. These are the disease we'll try to cover. To reach a diagnosis, to introduce the respiratory system, I have placed some of the diseases that is more relevant to respiratory system. So when there will be a question that please tell me some respiratory diseases, so you tell or mention the diseases. Don't be alerted to know the diseases to be learned. To reach a diagnosis, I think you are in the 5th year, new 5th year, so you are already in knowledge that to reach a diagnosis and to treat a patient, we try to first understand through the history. What are the respiratory system history? That is important. That is important that the diseases related to respiratory system, the patient will give a history. So in history taking, there is a system of history taking. So in respiratory system, what are the complaints by the patient? Please write down. First thing, patient will complain that I have shortness of breath. That is dyspnea. But patient will not tell dyspnea. Patient will tell that I have breathlessness. I have shortness of breath. I have labored breath. So what is that? There is a definition for the breathlessness or shortness of breath is that the patient is aware of the respiration. The part of respiration comprising inspiration and expiration, patient is aware. Because when our heart is beating, we are not aware that heart is beating. It is going on. When there is palpitation, then the presence of the heart is aware. Like the same thing, when we are taking the respiration, in every minute, at least 12 times, 12 to 18, better 14 to 18 is the normal respiratory rate. If it is below that respiratory rate, that is below 12, it is pathological. Above 18, it is pathological. Please remember. So in any form, low respiratory rate, suppose the respiratory rate less than 8, need intubation. Respiratory rates more than 18, need oxygenation. So these are the respiratory rate more than 25. It is a criteria of acute severe asthma. Respiratory rate more than 30. It is an acute pneumonia. So pneumonia in presence of respiratory rate by curve 65, we learn that, but it is the respiratory rate. Simply the respiratory rate will guide to a disease. Respiratory rate more than 35 need also intubation, mechanical ventilation. So I think you understand. So awareness of the respiratory rate that I am breathing in and out, it is the breathlessness. It is not only the shortness of the rate, but it is the feeling by the patient. So breathlessness, shortness of breath, short of breath, SOB, there are many. Dyspnea is the medical term. There are many if there is a chance, because it is the main topics in the third year. But to start with the respiratory system, we must be clear this what the patient want to tell. Sometimes the patient also non-pathological condition can give a respiratory rate higher. So it is a not the shortness of breath, it is the hyperventilation. Suppose a hysteric patient, psychogenic patient, after having exercise or emotions, respiratory rate increases. So that is hyperventilation and the shortness of breath. You have to get the knowledge how to differentiate it is pathological or it is non-pathological. So in pathological condition, need the appropriate measures and reach a diagnosis and treat. So after shortness of breath, patient may tell that I have cough. It is another respiratory system complaints. So cough. Regarding the cough, it is not the sputum. Please remember, it may be productive, means it have production of the respiratory secretion and coughed out, maybe greeny, serous, maybe hemorrhagic, maybe frankly blood stained. So the cough, dry cough, productive cough with purulent nature. You have to understand if the intelligent patient tell that I have a productive cough with yellow color. So that means an infection is going inside. And only serous cough for long standing time, goblet cells, hyper-responsive, like bronchial asthma, allergic. So I think it is clear now regarding the cough, you have to clarify this situation. It is short-lived, short-generated, newly developed, recent, or chronic. It is very important on the history. Where I am in the history. This is the principal part to reach a diagnosis. And after reaching the diagnosis, we can treat the patient. No diagnosis, treatment is elusive. So all our target to reach a diagnosis and to have a clue to have the diagnosis near to the real diagnosis, or it may be differential diagnosis, because one diagnosis cannot fit the whole systemic presentation. So that's why we are telling that there is a provisional diagnosis, there will be differential diagnosis, and there is a confirmed diagnosis. So this part of the diagnosis, after we have already told the shortness of breath and the cough. So only dry cough, that means goblet cells or the secretory cells of the lung or airways are not producing the enough secretion to be coughed out. So it is dry. That means patient have a responsive to the stimulus of the stress of the receptor of the lung. That's why suppose an irritant is irritating, patient has a cough reflex, patient is overstressed, cough reflex. So these are chemical. Sometimes chemical inhalation or chemical introduction can stimulate, and the receptor, the cough receptors are stimulated, and it is, I think possibly you know this. So these are related to cough. We clarify the cough 2 weeks, 3 weeks, 5 months, over many days, and it is continuous or episodic. This is also important because in bronchial asthma, patient may have cough, but it is episodic. It is not a continuous. When patient is healthy, he or she has no complaint of cough, chest tightness, or shortness of breath. During the normal condition, patient is having completely normal, no physical presentation, no complaint of the patient. Again, after 3 months, after the attack or after the precipitating factors, patient may respond. So this, after that, we are very interested for the hemoptysis, but it is medical term. Never write hemoptysis, never write dyspnea. Huh? Write is at the patient's word that blood coughing, coughing out blood is hemoptysis. So be careful about the complaints. So you will be able to understand and investigate and manage. So hemoptysis, what are the hemoptysis means? Simply it is a blood coughing, coughing out of blood, and it should be from the respiratory source. It is the main difficulties arises that the hemoptysis is very alarming. Patient usually don't miss. Patient always tell that আমার কাশির সাথে রক্ত আসছে অথবা blood is coming with coughing. So how will differentiate between coughing out blood and vomiting of blood or blood mix? That is, how will differentiate clinically, biochemically, the hemoptysis and hematomas. Today is introductory class. I'll not cover all the thing, but just passes. So hemoptysis. Just I will tell some words of the hemoptysis. That is, if it is hemoptysis, simple thing that it come with the coughs, but it is mixed with the respiratory secretions. On the opposite side, hematomas, it is the food or the gastric content mixed. Usually color. Color is most differentiating that patient has hemoptysis. It is a fresh blood. Patient have hematomas. It is a coffee or coffee ground or altered blood. I think you know this thing. Just so by seeing the content and the appearance of the cough, you can tell that it is fresh. Another point is that clotted. So if there is a small part of the clots are available on the contents, that is more sure that it is a respiratory source because there is no dilution and there is no acid mixation. So there is no mixing with the other content like gastric. So it is fresh and clotted and having, of course, the more in favor of alkalinity. So it is respiratory source means it is a alkaline in biochemically fresh blood, or it is the color of the blood and it is clotted. Very important that in case of hematomas, this is the vomiting out blood. It is the gastric source, gastrointestinal sources. So this will happen that it is usually more liquid with the gastric contents and unclotted and color is changed. Color is having as I mentioned. So, of course, the other clinical features, if it is a good question also in Dhaka University, is that please write hematomas and hemoptysis differentiating points. So you have to write another point that diseases contributing to the hemoptysis and contributing to the gastric or the hematomas will be available. Suppose how it is available. So you must remember the causes of hemoptysis. What are the, at least for cause of the hemoptysis or cause of any diseases, etiological factors or etiological explanation, you must be very clearly understood that at least 3 common causes should be mentioned. 3 common causes. Please write and remember and practice. Then the 5 causes, the 3 commonest causes, 5 common causes, and start the rare causes. This should be the all sources, like shortness of breath. There are common causes of shortness of breath, commonest causes of shortness of breath, and the other causes of the shortness of breath. This acute shortness of breath and chronic shortness of breath. Just I will finish the hemoptysis, then I will come to that point. In the hemoptysis, usually it should be mentioned in the first 3 causes, that pulmonary tuberculosis with bronchogenic carcinoma, lung abscess, pulmonary embolism, and of course the anticoagulant the other causes. Then the pneumonia, cough, and this so on. There are other diseases coming. So please remember, like the shortness of breath, acute shortness of breath and chronic shortness of breath, there should be differentiated. Acute shortness of breath is hours or days. Also, you tell the first 3 commonest cause, then the 5 common cause, then the other rare causes. So the answer and the examiners will be more satisfied and pleased if you can tell the suppose the hemoptysis, you tell that pulmonary embolism. It is a very rare condition. It is a very rare condition. So be careful about that. Acute respiratory shortness of breath or acute shortness of breath, you must tell, I think you know all this thing, just it is a recapitulation, that acute severe bronchial asthma, acute exacerbation of COPD, and severe pneumonia. This should be the 3 commonest cause. From respiratory, if want to add other system, that should be acute left ventricular failure. So all examiner will be happy if you can tell these 4 causes on the top of the list of causes. So you at the time of being students of new 5th year, you are already acquainted, but you don't know how to place it, how to tell in order. So from today, this is the guidelines, that after that, there are many other conditions that can go, suppose pneumothorax. It is not common, but it is also not commonest, but it is the under the common, the pneumothorax, the severity. So that is a cause of upper airway obstruction. It is another cause. So hysteric or psychogenic causes of the acute or shortness of breath, that is another condition. So be careful about the presentation and the acute. Chronic, there are many conditions of chronic condition, but we are, remember the question. Question is, tell me the causes of acute shortness of breath. As I mentioned, there are many rare causes, but these are the 5, 6 should be in the commonest type of causes. And then they want to differentiate. Suppose in acute left ventricular failure, patient will be shortness, will having dyspnea, but patient will have a orthopneic type of dyspnea. That is when the patient lie down on the blood, only patient become dyspneic. In acute severe asthma, this is and other COPD, this that causes the chairman type of dyspnea, that is sitting, still dyspnea, and all dyspnea increases on lying, but all dyspnea improves on lying prone. That is like the now the corona and other changes, cough, the COVID-19 improvement by the prone and respiration. Of course, the oxygenation other. Other things that must be with the respiratory system, that is that chest tightness. Chest tightness. This patient may tell that I have chest pain, chest tightness. These are two words, but the patient is patient and layman cannot describe the real situation. It is you to understand and get it clear from the patient that is it a chest pain, and the pain should be localized, side, periphery, central, back, radiation, of course the time and source and origin and duration. All these 7 points should be related to the chest tightness or chest pain. Suppose chest pain is not a complaint of bronchial asthma, but chest tightness is a complaint that I cannot breathe out. So chest tightness, sometime in case of acute myocardial infarction, patient tell that I have tight, heavy chest, cannot tell that I have pain. And also the myocardial infarction can tell that I have left-sided precordial, cannot tell precordial, it is centered closer to the heart. These all terms is medical. This precordial, central, cannot tell. On the left side of my chest, possibly centrally placed, there is radiation to the left hand, upper torso, hands, fingers, sometime to the abdomen, back. This is very descriptive to the typical presentation, atypical presentation. So it is the knowledge, the time, and the years. You will get it through your endeavor, how you're exposed and how you understand the patient and handle it. So it is a word related experience upon the theory. This is a theory class. This is I am telling about because it is patient is not in front of us. So be careful what to ask. So where is the chest pain? This is it pleuritic for the respiratory system? Common question usually asked that is it a respiratory system related chest pain, or it is other non-cardiac pain, or it is a cardiac pain. So in the chest pain and chest tightness, first thing you must remember, is it cardiac? It is non-cardiac. In non-cardiac, is it respiratory? Other, suppose herpes zoster, pain, trauma. This may be related to the boil cellulitis. Even the can cause the chest pain. Bone chondritis, Testis syndrome. These are the musculoskeletal cause of the pain. This is the commonest. So you must be. Then the respiratory, if it is a pleuritic in the respiratory system, also the ribs and other, the pleura involvement, the involvement of the phrenic nerve, diaphragm, phrenic nerve, the cervical foot, now the phrenic nerve supplying the So diaphragm. So diaphragmatic nerve in bronchogenic carcinoma usually involved, and the diaphragm get out inside the chest. Patient will be dyspneic. Patient will tell that I have pain, but this pain is related to the original disease like bronchogenic carcinoma, tuberculosis, lymphoma, other malignancy disease that can damage the nerve and can put up this system. Otherwise, suppose pneumonia, commonest, community acquired pneumonia, CAP, that will cause also chest pain, but usually in the periphery, never in the center. When we will teach the pneumonia, then we will understand. But the pneumonic chest pain usually present as a pleuritic type of chest pain, because lung parenchyma practically is painless. But when the pleura is involved, it is painful. So when during stressing of the breathing in, that is inspiration, that is more important, that when the patient is normally taking breath, cannot feel the pain. But when get is more deep inspiration, patient breath hold during full inspiration is a pleuritic type of chest pain. So when there is pleura is stressed, the pain is more experienced and the patient cannot get full inspiration. So what is the pleuritic chest pain? Pleuritic chest pain is the pain during deep inspiration. It is an indicator that the pleura is involved. So there is pleuritis. There is pleurisy. So pneumonia with pleurisy, pneumonia with pleuritis will make the pleuritic type of chest pain. So cannot breathe, and so there is shortness of breath. Okay. If you cannot take the full inspiration, always remember the inspiratory force and expiratory force, the timing. Suppose a patient is taking 12 respiration per minute. So one respiration is 5 seconds. One respiration is 5 seconds. So what happened? In respiratory phase, I think you know that in the normal respiration, there is one active phase and one passive phase. One passive phase. The passive phase is the expiratory phase. Active phase is the inspiratory phase. Alaikum
স্যার
assalam.
একজন ডিসকানেক্ট হয়ে গেছে, একটু অ্যাকসেপ্ট করতে হবে।
এটা তো অ্যাকসেপ্ট তো আসছে, আচ্ছা ঠিক আছে, আসছে মনে হয় এখন, হ্যাঁ ঠিক আছে, থ্যাংক ইউ। তো so pleura is involved, pain is there, pleurisy is there, pleuritis is there, tuberculosis, pleurisy, pneumonia, pleurisy, bronchogenic carcinoma, pleurisy will make the pleuritic types of changes. So pleuritic type of chest pain will never occur in cardiac diseases. So it is one of the differentiation. In cardiac diseases, there is shortness of breath, there is chest pain, but there is this typical location, position, radiation, timing, so you can define, and also relieving factors, precipitating factors and relieving factors. So all the respiratory symptoms you have to mention by the duration and the qualities. So it is you to make it clear by your endeavor. You have to read it. That's why I have mentioned the diseases. You must go through the diseases and can understand what probable causes of the disease production, pathology, symptoms, diagnosis. Of course, the management is another terminal part. Fifth year is the management part. Third year is the symptomatic part. Fourth year is the investigative part. So you must remember that you know how to reach a diagnosis. After that, investigation. After that, treatment. Now you must know the dose, drugs, and duration. These 3D you must know, and other things is so. But before that, I believe, because of the corona and other separation, corona has make us a bit distant. That's why you are not more acquainted as before. The responses and other, we should now cover up the thing. What is lost is lost, but get it covered. It is still have time, and the time can make you up. So please remember. So I was in the chest pain type. So chest pain is a symptom. Chest tightness is a symptom. Then the specific from where I was, that suppose it is a bronchogenic carcinoma, lung abscess,